Good evening, everyone, and Palofalava. Welcome to tonight's Goodfellow Unit Webinar on Common Aviation Medicine topics. My name is Dr. Hazel Fuyava, and I'm a GP in South Auckland, and I work for the Goodfellow Unit. Tonight, we're hearing from Dr. Kit Boys. Now, Kit is a GP and an Aerospace Medicine Fellow. Kit has been a member of the Royal New Zealand Air Force since 2010. He was a lawyer for over 10 years before changing careers into medicine, and Kit is the clinical lead at the Royal New Zealand Air Force Base in Whenuapai. And I will now hand over to Kit. Thank you.
Thanks, Hazel. What I was going to talk about is medical issues and aviation environment issues. And in particular, that sort of comes down to two areas. If you're worried about aircrew, there's sudden incapacitation, impaired judgment, not risks and things like that. But if you're worried about travel in the aircraft, and there's a different set of sort of the environmental threats to you. So I'm going to run through both of those, and I hope that it'll explain some of the other stuff. Begin with, many of you will have heard the saying, if God had meant us to fly, we would have had wings, or would have bought us an aircraft ticket, is another version which has floated around. And flying is a little bit different. We have legs adapted to walking, eyes and arms adapted to climbing trees, vision with a range that can cope with the dark of caves. We've got in our skin an unusual layer of subcutaneous insulating, streamlining fat. And we've got noses and airflow, which for primates are unusually adapted to time and water. Some of us with Central African ancestry carry adaptations to heat. Some of us with European and Neanderthal ancestry have adaptations to cold. We're adapted very well as humans to extremes of life on the surface of Earth, both the land and even to some extent in the water, but none of us have wings or feathers or bird bones or bird lungs, which are so much lighter and more efficient than our own. Our bodies are well adapted to life on the surface of the Earth or close to it, but they're not adapted to fly. So what goes on above the Earth? So gases are not like liquids. They're compressible. I'm probably teaching you all to suck eggs, that, because you know it. They also expand as pressure drops. Half our atmosphere is beneath 18,000 feet or 6,000 meters. It's held onto the Earth by gravity. As pressure drops, there's less air, the temperature drops, and there's less oxygen. So there's a bunch of stressors that come out of that for people flying. Cold, less oxygen, and with less oxygen, we see less well. Color and night vision begins to be impaired. We think less well, but eventually we don't have enough oxygen to stay conscious. So that's sort of the basics of the environment, but a lot of other stresses are caused by how we get up into that air environment. So how do we fly? So we have attempted for quite some time to fly, and as I said, we're not well adapted to it. But there have been a variety of efforts that have different impacts on how well we do it. The first that really took off, no pun, and well, apologies for the puns as dad jokes may come, is balloons. So balloons you can control going up and down, but you can't really control direction. The next slide, was airships. Or gliders. Let's talk about gliders. So gliders, which did come around about the same time, you can control the up and down and sort of a bit the direction. Well, at least you can control the down, or at least the rate of down. Then with airships, hopefully that's in the next one, you can control up and down and sort of direction, although they're not very good in bad weather. Now, one thing you may have noticed as we've gone through is most of these are rather old photos, but in each one there's been a relatively new example, whether that was the somewhat vaporware example of a stratospheric tourist balloon or the Airlander airship there. So none of these things have really gone away, and some of them may become more relevant in the future. Also, things like ballooning and gliding are actually quite common recreational activities, so you will have people doing them. And then after this, we got aircraft, which come in a great range of different types. So often when I'm talking to people, they tend to think about airliners because this is what they know, or maybe a private plane, but there's actually a great deal of variety in the sort of things that can go flying because of that, a great deal of variety to the stressors that people are exposed to in them. And then we've got helicopters. Now, with helicopters, you can control, I should have said with aircraft, you can control up, down, direction, provided you've got enough fuel and speed and a big, long runway to land on. With helicopters, you can control the up, down, and the direction, provided you have enough fuel and vibration. The final example I'll use is rockets, which gets a lot of attention because everybody likes the space part of aerospace. Rocket Lab hasn't yet launched anybody from New Zealand into space, but it's relevant in aviation medicine, particularly because of the hazards on the ground. Rockets, you can control the up and the direction, provided you've got enough fuel and speed and enough environmental resource consents, which is certainly a major impact. Now, one thing I haven't put in here, but should mention, is drones, which is something you can fly provided you're not in it. We're also getting some increasing number of questions about drones from near a medical point of view. Sometimes that's using them medically, particularly to deliver supplies to places where it's difficult to get to. That's probably more of a military issue than a civilian one. But the other one we've got is once drones are over a certain size, then you need to have be accredited as a drone pilot, including a medical component to it. For most things that you're going to meet, that's just the driver's license standard. But it is possible that you'll encounter somebody who's flying larger drones, and then you begin to get some of the responsibilities to report medical issues that go with flying a full-size aircraft. Okay, so hazards that come from all these different forms of flight. Let's go back to take the next picture. As I mentioned before, when you go into the atmosphere, you go up into an unfamiliar environment. Another thing that happens with flying, an advantage of it is that you can travel over anything. If you walk, you're going to get stopped by the ocean and slowed down a lot by a swamp or a mountain. If you are at sea, then the shore tends to stop you. With air, an advantage of flying is that you can just go over the top of pretty much all of this now that we're flying high enough to avoid mountains, hopefully. And assuming that you've got okay weather, which for large commercial aircraft, most weather is something you can move through. A downside of this is where you are. So if there's a problem in flight, an important thing to remember with an aircraft, as distinct from a car, is you can't pull over to the side of the road, stop and hop out. That is very relevant when CAA has given into, or the government has given into pressure to allow people to fly on driver's licenses. So here's a couple of random photos from flying this year. Wall to wall, absolutely nothing, which is over the Pacific. And the other one is from over Antarctica a few weeks ago. Both of these are places where if there's a problem with the plane, or a medical issue on the plane, there's not an awful lot you can do about it in terms of immediately sending somebody to hospital. So that's worth considering, particularly if you're dealing with the people who are in control of the aircraft, because if they have a medical event, as I said, you can't just park the aircraft. Even helicopters, it doesn't tend to work very well. To give some practical examples, because I thought it was better to sort of talk about that as we go through. If you've got somebody with, say, visual aura or migraine, I'm used to doing Q&A and asking how many people would stop them from driving a car, or indeed a commercial vehicle. And the answer will be none of you, I'm sure. But if you have a visual aura migraine and you're flying a plane, that's a big problem. If you have anything which is likely to be suddenly disabling, then it's not necessarily a good idea for you to operate an aircraft. But this is a problem if you have somebody who walks in and says that they just need you to do a commercial driver's license test from DL9 because they want to use that to fly an aircraft. It is an awkward area where in the past I have recommended people let CAA know about that as a potential problem and leave it over to them. And I must admit, talking to CAA and particularly talking to some of the other nations are looking with interest at us in New Zealand doing this fly on a driver's license. And the Australians have quite bluntly said that they're under a lot of pressure to copy us. So they're watching us closely because sooner or later somebody's got to crash a plane because of it, and they'll use that as the reason why not to. But it is an awkward area, and for the good of your patients, it might be advisable to try and let them know that maybe flying by themselves is not such a good idea. When you've got to explain that to people, I find getting them to think about who else is in the aircraft can be useful. And also another thing, if they really want to fly, and pilots are known for "I must fly," then as or with co-pilots, having somebody else who could grab the controls can be a compromise. Okay, as I said, you can't stop and park the aircraft. You can't open the door. Some other things about flying, which are a bit different to the other means of transport, like walking, cars, or boats. It's very expensive. It's also very complicated. There's a lot of things that can go wrong. Despite that, the aviation industry has one of the best safety records of any form of transport. For distance traveled, it is basically the safest way to go anywhere. It is safer than walking on the footpath in terms of distance traveled if you're in a commercial airliner. Much less so if you're in an antique warbird doing aerobatics. But how did it achieve that degree of safety? Well, part of it is to do with the engineering and trying to make sure the wings don't fall off and things like that. Some of the very first aircraft you saw weren't necessarily that well built for. But a large part of it is by having some rules that are quite strict sometimes about who can fly and who can't. And that, when I was talking about stuff that you're obliged to notify CAA about, is relevant. So where I was talking about driver's license and somebody with, I'm picking on visual aura migraines, somebody with that, well, you might suggest it's a bad idea. If you find you've got a pilot who's got visual aura migraines that have just started, you got to tell CAA. If they've had a stroke or a heart attack, you're obliged to tell CAA. And these are things that might not occur as a commercial driver, that you might need to get permission to do this. Some of the things are exactly the same. If you've had somebody who's had a tonic-clonic seizure, well, it's just the same as driving. But do bear in mind that if you know that they've got a flying license and they've had, my rule of thumb is rather than go through a list of conditions, just say anything which could be suddenly incapacitating, then you've got a duty to tell CAA. And that can be some surprising things. Including things which could be. So they've got a bunch of stones that are large enough just to pass down the renal tract. You're not going to be very good flying a plane solo with renal colic. So that's something that you need to tell CAA about. In theory, no, is that the obligation just on you? No, absolutely. The obligation is also on the pilots. But they don't have a great record for remembering to do that always. Most of them are pretty good. But sometimes they will deliberately not. And more often, they just won't think about it. And renal colic's a good example of that, but I'm not in pain now. A common issue we get with that is the understanding of risk. And this is vitally important to understand how it's so safe to go flying in a metal tube up where the temperature is minus 55 degrees and you've got 30 seconds of useful consciousness should you be exposed to the outside atmosphere. Why is it safe? Because of all the cuts and balances and a very low tolerance for risk. People often have this idea of fairness. If it's less likely that a condition will happen, it's less than 50% chance, probably won't. Well, it's probably not going to happen. Surely I should be allowed to fly with it. No, as a rough rule of thumb, a commonly used thing in the aviation industry is 1%. If it's got a 1% chance of happening per annum, then no, as far as incapacitating events go. And that can be very hard. If you think in terms of age, once somebody is beginning to get up into their 60s, and anybody, no matter how good they are by their 70s, then the risk of a cardiovascular event becomes greater than 1% a year. And that's certainly having an impact on pilots, and it is driving a push. There's a lot of strong advocacy. Pilots feel, as a group, tend to feel very strongly about their right to keep flying. And it can be quite corrosive to your relationship as a doctor, where you've got to try and make it safe. As I said, there are ways you can do that. And surprisingly, some of this can be, well, as or with a co-pilot, so somebody else who can grab the controls beside you. Hey, that's most commercial airliners. In some ways, that's actually safer than somebody doing aerobatics in a jet over a city by themselves. And speaking about pilots, I might just take and the changes that changing environments they can go into. I might just move on to the next slide. So this is showing how risks have changed, but also how protective equipment has changed, both with time, but also with what people are flying. So you can see the difference between our pilot on the right of your screen, who's who I actually can't see the way this is set up. He's going back to look, but I'm sure she's wearing not an awful lot. She's got a bushy, a sort of hat that I would be very worried will blow off in the slipstream. She's got no gloves, no real protection against burns. I'm hoping she doesn't fall out of that if the aircraft goes down suddenly, which has happened in the early days quite a few times and has continued to happen to the modern day to people in open cockpit aircraft who aren't very good at doing up their seatbelts properly. And then you begin to see protective equipment come along. So the bottom center, we've got goggles. That's a good idea for eye protection because you've got a lot of wind blast going on as speeds rise up. You've got warm clothes because as you go up, you get cold, and in particular, big solid furry gloves there. Although you can't see it, that'll also be able to wrap around her mouth so that she's going to be protected from cold there. What she doesn't have is a supply of oxygen. Now, our helicopter pilot straight above her, there you see the addition of Nomex, which is a fireproof form of fabric. He grabs some of his own in the background, which significantly reduces the risk of burns, which has long been a major problem, and gloves in the pocket and so forth. Moving on to our F-18 pilot on the top left, oxygen mask with a positive pressure. So this is almost like a CPAP. It'll blow oxygen into you, which is important, particularly if once you get quite high. And if you don't have full pressurization, then the lack of pressure can become a significant issue. This is also the case if you think about fluid laws. You know that water boils at a lower temperature as you go up a mountain. If you get high enough, water boils at just 37 degrees, which is a significant problem if you're in the aircraft at that time. What you probably can't see, some of the stuff around the front is designed to inflate as G pressures rise. So if you want to turn a corner when you're going really fast, then that generates a lot of centrifugal type pressure, G forces, and certainly the aircraft behind her is capable of pulling 9G. Without the benefit of the G suit, all of us would be unconscious very rapidly with that 9G. Taking that one step further in the bottom left, this is a pilot who's going to work at extreme altitude. So that's a full pressure suit. And the aircraft that she's flying is capable of flight at well over 80,000 feet. And at that point, from a physiological point of view, you might as well be in space. So that's actually very close to an astronaut suit. So that's sort of a rough idea, partly of the different sort of protective clothing people can wear, but also of the idea that it's not just in the back of a commercial airliner. There are differences depending upon what you're flying in. It can be a good thing to ask people is what sort of flying are they doing if they're doing their own flying. If you're in a microlight, effectively your technology level is not particularly different to the picture on the far right. Whereas even in our Air Force, we do have some people who are doing similar sorts of things to the top left. There's a large private flying community which looks like they're flying along in t-shirt and jeans. In fact, they might be, but they don't have the pressurization, and they are suffering from the problems of going up in altitude, hyperbaric hypoxia, and all the problems which come with it. I might just talk a little bit about cliches about aircrew and pilots versus what people are actually after. So on the left, I think we've got the two examples of what people tend to think about those who have a career flying. And traditionally, there was a certain amount of you were out of communication with other people, certainly in the very early days. You needed to be fairly brave because literally the Blackadder comments about your life expectancy being 20 hours flying were quite accurate in World War I for several people. It took a bit of an attitude, it took a bit of independence, it took a bit of initiative, the willingness to make decisions, and it took a bit of bravery. This is to a degree the same sort of behaviour which gets people into trouble at Friday nights and visiting ED. And it's not the sort of person that we'd actually like to hire these days to fly an airliner or a military aircraft. And we've got a bit of a gap between a lot of the people who want to fly, having read Biggles as a child, or those who and what the industry would like out of the people who go flying. So if you have a look on the right, again, that was a photo I took a couple of weeks ago when I was flying in the jump seat of one of our Hercules. People also tend to think of aviation as highly advanced. Now, that's got some cockpits that were redone 15 odd years ago, but the basic airframe is 1965. So not necessarily the highest tech piece of equipment ever, but incredibly complicated, very well maintained. And to keep it going, we've got a couple of pilots. We've got an air engineer in the middle whose job is to look after the engines, to hydraulics, etc., all the other bits of equipment. We've got what's a navigator basically on the right, and her job's to work out where you are, but it's also got a lot of work to do with communication and other bits and pieces. And what's not shown is load masters who can have control over such important things as making sure that the weight's right in the back of the plane and checking the systems as it's in the air. So to make that lot work, if you've got your gung-ho, let's just do it, psychological attitude, it's going to turn into a big mess. We can't afford people, to quote from Top Gun, because somebody must, whose ego is writing checks that their body can't cash, or that their personality can't cash. We need people who won't clash, people who will be able to communicate well and do what we call crew resource management, which is a good way of saying to be able to work together as a team with anybody able to put their hand up and say there's a problem. And if you've been involved in surgery in hospital, you hang on, this is ringing a bell. And that is because aviation has has come up with quite a few ideas that have been cheerfully adopted by the medical community. So the whole crew resource management idea has now moved into the operating theatre, with the idea that it doesn't matter if you are the first-year house surgeon or the medical student. If you see someone doing something that you think's a bit dangerous, you can put your hand up. And in fact, you're expected to, and you should be able to do that without having the orthopedic surgeon give you a lecture about how unimportant you are in the world. So why am I telling you all of this? Well, partly it's to get into psychological issues in flying, and to say that there can be quite a bit of a disjoint between the sort of person you might think would be a good pilot, who we think would make a good pilot, and some dangerous signs for pilots. So the hard drinking, risk-taking sort of behavior that's in the movies is actually not a great thing. Having said that, the sort of person who fits in well in this environment can be vulnerable to some things. For example, our people who fix aircraft have a very high instance of obsessive compulsive disorder. They go and check, did I get the torque right on that bolt? I think I better go check again. Great, the aviation industry loves that. I better make sure that there's definitely none of that horribly toxic chemical in the. Great, the aviation industry loves that. Sometimes it can be counterintuitive, just like the aviation environment is. For example, if you speed turns into height and vice versa. So if you get lost, flying low and slow to be careful does not work. But I'm getting a little bit sidetracked with there. What I should probably do is move on to some of the other aviation issues and things that's probably more relevant to you in practice. Noise. So if you've got aircrew, I couldn't find an accurate one. Jet engine frequency is 6,000 hertz, almost universally. There'll be a 6,000 hertz notch. Equally, if you've got some hearing difficulties and you're around aircraft are very good for making it worse and more difficult to understand things. Conversational range, fortunately, is normally preserved, but it can be quite difficult to communicate, which is a problem if you're shifting somebody by ear or trying to talk to somebody in a plane. And people who work in the aviation industry do need to have regular checks. If they are having, for example, your classic occupational notch, that's something that there can be an ACC claim in, if they're military, the Veterans Affairs claim, and it means to access some compensation. But noise is a major hazard of flying, particularly in non-commercial airliners. So if you're outside that commercial environment, everything gets much more noisy. I mentioned before that we're working in an atmosphere now, and gases, a certain amount of gas will expand to fill the available space. I'm not going to go into Boyle's law or anything like that, but the net result is when you go up, gases expand. When you come down, they shrink. Issues which can cause a problem for your patients when flying, and this really does apply to small children in particular. If you've got cold, then the chances are you've got a bit of you've got some fluid in your sinuses, and you may well have some go up and give you a bit of otitis media, or just some fluid sitting there. Many of you may have noticed, if you just start looking in people's eardrums, the number of people who are sitting there with little fluid meniscus, quite a lot of the time from a hay fever or whatever, is quite high. And normally that causes no problems at all. Like often Valsalva, which is good at ground level. The problem dealing with the ears to begin with, when you go up, the eustachian tube acts like the neck of a balloon. Air expands, it just gets squirted out. Not a problem going up. But when you come down, it gets sucked shut. And once it's sucked shut, then that causes the eardrum to get sucked in, and that is really very painful indeed, particularly for small children. So this is a classic baby in a plane screaming on descent problem. How do you deal with that? First of all, if you know they're going to go flying, and then you know that they've got an existing problem, Otravene's your friend. Persuade them a couple of shots in, but then up, and after that, up and towards where the eustachian tube is. Constantly valsalvaing, so clasp your nose, strain like you're on the loo, or however you wish to say it, and see if you can get those ears to go pop. If you stay ahead of the curve as you start descending, things will help much better. It will go much better. Feeding or drinking, swallowing really helps this. This is why airlines give you sweets on the plane, is to get you sucking on something, because that's really likely to enable you to clear your ears. So breastfeeding on descent is an excellent idea. Bottle on descent is an excellent idea. Sucking on a lolly on descent is an excellent idea. Even chewing gum is a good idea for kids. Other problems which can go on with this, a bit of sinus congestion. One, good luck getting through an airport in the post-COVID era, leaving that aside. Two, so as you can see, frontal sinuses will the drainage holes towards the bottom, so the fluid tends to obstruct, which means you get ouch more on the way up. Maxillary sinuses, for a variety of reasons, that can happen too, but you can also get some ouch on the way down. One thing which can cause quite a bit of anxiety and often a bit of abdominal pain is the fact that gases in your intestine will also expand. In the words of Shrek, better out than in. Should you be dealing with somebody with that, incidentally, rolling your fist into your abdomen, just moving gradually. Sorry, I don't know if anybody's watching me. Gradually, nobody wants to look at my belly probably. Actually just rolling it across like that can help gases to come out. And certainly it's not an unexpected thing, and trying not to pass wind because you're in an aircraft is probably not particularly good for you. Which point you may be saying, no, I skipped this earlier, but aren't airliners pressurized? Why do my ears go pop? Well, airliners are only partially pressurized. Usually they go to an altitude of 6,000 to 8,000 feet in cabin altitude while flying at anywhere between 25 and 40,000 feet actual altitude. Occasionally, you're going to run into either people who are operating unpressurized aircraft. Virtually no helicopters are pressurized. Smaller private aircraft aren't. Or you may have to deal with a commercial aircraft which is depressurized, and I can deal with that in questions if people want me to. Okay, so that's gases. Gases expand. Very rarely, if you're looking at shifting patients, other places gases can be that are bad. Inside eyes, inside the brain, that's a really bad one to go flying with. You could also have inappropriate air, well, most of the places you can think of under the diaphragm, air in the mediastinum, things like that. All of those are going to expand and present you with a problem. Okay, our teeth. Very occasionally, if you've had deep root canal work and fly straight afterwards, that can go badly too for the same reason. Okay, yeah, so children on planes. Other tips regarding children. And thank you very much for my daughters for involuntarily becoming the models for this lot. Issues you can have are anxiety, pain for the reasons I've mentioned. The biggest one which comes up repeatedly is boredom and sort of acting out. So things that you can try and do to deal with the anxiety side of it, modeling for children what a flight's going to be like, what to expect. Expect that you will be in a seat for some time, that there will be announcements, there will be noises, that you will feel like the pressure of being pushed back in your seat and so on. And the aircraft will feel like it's going down, and there may be a bit of turbulence, and this is all okay. Having something to do, particularly, I would not trust anybody's AV system, although that's fantastic if you've got it. Having something else to do in the flight. Also being quick to get on top of things like somebody who's got sore ears, with sort of advice I just gave. A bag of sweets or something like that is really helpful. I'm sure you've all encountered the difference between an unfed and a fed child, particularly when they're stressed in terms of getting them through things. Getting up and down and just having a quick walk up and down the cabin of the aircraft can be really good, can help just that tiny bit of adrenaline or whatever burn off, and help with the restlessness and a bit of variety. Change which seat you're all sitting in. Infectious diseases and aircraft. So we all did COVID. Some of these naturally working at a port of entry, and for an air carrier, got a lot of this screening everybody who came in, and also helping. What's the picture there is some of the workers from Vanuatu returning to Vanuatu, where basically they're on their way to the local equivalent of a MIF. So we work in a much heightened environment of concern about infectious diseases and planes. And let's be blunt, how do infectious diseases spread around the world? Aircraft. We did it. There's a lot of PR about the low risk of catching something on an aircraft, which is pretty much true. But also, where did those diseases come in? Well, okay, we did get a bit of COVID through the maritime environment, but most of it came by air, and most of it will for an island nation like New Zealand. I don't know if people have heard of international health regulations. Very few had prior to COVID, but we have some obligations related to entry into New Zealand and screening people. This is something which we've got, I think the general public didn't understand well, the concept of pratique, that no one, doesn't matter if you're a citizen or not, no one has an automatic right of entry into the country, and has not done so for most of New Zealand's existence. And that's the case throughout the world, that you've got the right to put people who may be diseased into quarantine and who actually are diseased into isolation. Two words that got mixed up a little bit in the government and media discussions. But that is something that is worth knowing. If you're sending somebody who's infectious on an aircraft, and it's an infection which might not be something the nation they're going to has, well, they just don't know what it is, then you can hold up the aircraft and people may not be allowed off it. Real example, chicken pox, held up at Darwin. They weren't sure what the rash was. That was one I had to solve over the phone, just explain it was chicken pox, at which point you've got chicken pox in Australia, they can get off the plane. There are a set series of things: rash of unknown origin, nausea and vomiting which can't be explained. Spoiler, it's usually either motion sickness or alcohol. Temperature, fever which can't be explained. All of these things are something which the aircraft crew have a responsibility to declare and may stop people from being able to travel off an aircraft. There's also a lot of people worried about flying. So this is the idea pushed out by airlines for why you shouldn't need to worry. And they're quite right at one level. Your chance of actually getting something from a few seats away is relatively low. Basically, you're sharing air with probably about the 9 seats around you in the worst situation while you're seated. The problem with this is while you're seated. How does disease actually spread in air travel? Is in boarding. Airports, sorry, you're the big culprit here. Now, you did see, I forget whether that was Wellington or Auckland, but you've seen the photo of this attempt to maintain separation. The truth is most of air travel bears an unhealthy resemblance to this, and it doesn't really matter how good your HEPA filters are and your air circulation on the aircraft if people have been through this before and after boarding. So I suspect that's going to be something which will be an ongoing issue. And certainly if you've got people who are worried about catching diseases, this is where you really need to be wearing your masks. And if you've got somebody who may be infectious, this is the place they've called it a problem before you got the whole critique situation arise. A lot of people do have a fear of flying. Now, there are programs of desensitization, and if the worst comes to the worst, light dose of benzos can be useful, if not great for the DVTs, because you're a bit less mobile. But that's something that people may well present with, and it's something I treat like anxiety about anything else. As I just mentioned, for flying commercially, it's about the safest form of travel anywhere. Some people do get quite interested in what can go wrong and how to deal with it. So first of all, to deal with the myth out there, there's this idea that if an aircraft crashes, you're almost certainly toast and survival is a miracle. Not true. Commercial airliner crashing, odds are actually on your survival. And that's a large part due to a whole bunch of the safety measures and listening to what they say at the beginning. Count the number of rows. If it's all smoky, that's in Air New Zealand's one of their fire simulators for practice evacuation up top left. If the environment is very smoky and you can't see, you might be feeling your seats the way out. There are a variety, and how to work your life vest, how to get into the life raft. These things are important and do save lives. There are some forms of aviation which are more dangerous than others. We've got a helicopter underwater escape training unit there on the bottom right. And that's something that those of us who fly in helicopters regularly often have to do, is do practice to survive and get out. So reassuring people that they can undertake these sort of activities if, and I know I was speaking to somebody who worked with a journalist who had to fly in helicopters and was very worried about that, but had interestingly their organisation hadn't put them through the actual escape training and so forth, so hooking them into those sort of things I hope has been helpful.
Thank you, Kat. Awesome. Thank you for that talk, and I really enjoyed all the pictures. So, Kat, in terms of questions, so to start off, you mentioned a number of times the CAA.
Oh.
So I did a quick Google because I wasn't
Sorry,
familiar with
Civil Aviation Authority. Think
Right.
LTSA for flying.
What was that?
Think LTSA for flying.
Okay, cool. Yes, and what you're holding up there looks, is that their kind of guideline booklet? Medical
Yes,
Matters.
that's the guideline they put out.
Yes. Because the first question is, from the CAA, do they have any guidelines for health professionals, and how do we access those?
And yes, they do. Now, so they've got a website which is quite reasonable. You can ring them up and ask. And again, they are friendly. Tim Sprott's the head doctor there. He's very good value, ex-Air New Zealand doc. So if you do have questions, yes, get through to the medical team. They have a number of teams devoted to engineering and other issues, and both the website and initially the phone directory might look at channeling you to pilot who wants to know about flying in bad weather or something, but hunt down the medical side of it. And yes, there are some online resources there which will tell you these are the sort of things you need to worry about. These are the ones you don't. This is what you must tell us. And if you're in doubt, give them a call. I can certainly say that I've given them, I've dealt with them a bit about exactly that, giving them a call to say, I know this person's applying for a pilot's license. Here's the reason that I've got concerns. What would you like to do? And those are protected disclosures as well.
Okay, awesome. Yeah, I saw on their website they have a medical manual section, so that's obviously one resource. Outside of the CAA, are there any other resources for health professionals that are wanting to find answers to questions? And outside of who we might call via them, are there other people as well, or is that kind of the main go-to?
No, there's several places you could go depending on what you want to do. I suppose it's like any other area of medicine like that. So you've got a range of online information. If you wanted to do some study, Otago University has what's actually one of the few really good courses in the world on this. They've actually got a really good reputation. Australian National University is trying to start one up at the moment, so they've got some material. There are plenty of textbooks you can get on there that you can have a look at. These are available online for those people who don't like hard copy. Words of warning. There have been a couple of New Zealand aviation medicine textbooks published. One of them by Ross Ewing, an excellent doctor and ex-Skyhawk pilot. It's not particularly up to date, and there's a few things in there that I wouldn't necessarily rely on. We're hoping we'll get a rewrite done at some point. It is short and looks like it's New Zealand specific, but I'd go international. And the other one is Dave Baldwin, who some of you may know, doctor practicing out of Bulls. He's written one which is very much in the vernacular aimed at pilots. Some doctors may find it useful. Some doctors may find the language rather confronting. That's certainly entertaining, but yeah, it's aimed primarily at the pilots. So yeah, if you're after the detailed academic knowledge, I'd look internationally.
Is there a specific kind of aviation medicine training pathway in New Zealand?
There's a few different parts of aviation medicine. So aviation medicine can be heading down to be the very few of us who it's a large part of our jobs. It can be the person who does pilot medicals as an add-on to their practice, which is probably most people in the country who have it. It can be shifting sick patients in the back of planes, which is the two sort of big areas. We've got the occupational medicine side, and we've got the shifting sick people in the back of aircraft. I end up doing a bit of both of those, but often people do just one or the other, and they are quite different. In terms of qualifications, if you wanted to do sick people in the back of planes, you've got a range from the College of Anaesthetists has put out some guidelines with ED, which is basically you should be able to look after intubated, ventilated, blah, 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 blah. And then you've got some more practical guidelines for sort of the escort of the person who's not that unwell. Both of those are relevant areas, and you can do papers through Otago, which help deal with that academically. And the various organisations that do transport will do a bit of training, although they often look to people who've been trained elsewhere, Royal Flying Doctors, Air Force, whoever. Then you've got the occupational medicine side. So if you want to do the private pilots medicals or the commercial pilots medicals as an add-on to your practice, there's some study through Otago, some training with the CAA, and then you'll be able to do sign-offs for medicals. These are quite a bit more complicated than driver's license medicals. If you want to make a career out of it, now I'm biased as a fellow of it, the Australasian College of Aerospace Medicine. I do thoroughly recommend it. You can get your fellowship in that and be a speciality, albeit one the Medical Council of New Zealand does not recognise as a standalone. But they have a very good training program, and there's an attempt to start up in New Zealand, shifting between placements in Air New Zealand, with the CIA itself, and I wish with the Air Force, they were struggling a bit with that one. Certainly in Australia, you can definitely do that. Placement with the Australian Defence Force, placement with Civil Aviation Organisation, Government Authority, placement with airlines, get a balanced, rounded experience, and then like you're being a registrar, well, you are being a registrar in all of them, and pop out at the end with your fellowship. So that was probably a rather long answer.
Awesome, thank you, Kit. We have a question around DVT prophylaxis when flying, and whether aspirin has a role on that or not. So could you talk to that?
Short answer, no. The evidence base is not supportive of aspirin as useful as a prophylactic for DVT. Longer answer, what is? So either you're going heavy with anticoagulation, or, and that's appropriate sometimes for high-risk people, or advice, hydrate, walk, get up and walk up and down the aircraft, move your ankles, keep those calf pumps going. Where's the risk? So the risk is partly dehydration, partly some of the fluid effects that we talked about with a change in pressure, and much of it is immobilization. So a flight to London is equivalent to being stuck in your hospital bed post-op. Get out of the and sleeping the whole journey may not be a good idea. So maintain your hydration, get out of your seat, move, and if that's not that practical, do some exercises, wriggle your ankles, wriggle your legs around, wriggle your knees, get the calf pumps moving. Some people set an alarm to do that periodically. Often these days, airliners even have a sort of exercise app. You can even plug it in. Oh, interrupts your movie to say, remind you, move your legs. That sort of tip. If they're high risk, then yeah, you may need to consider medication. But unfortunately, aspirin, there's been a few studies on aspirin which show it doesn't really make a difference.
Okay, awesome. Thank you, Kit. Those are good practical things we can tell people. We have a question around medical clearance to fly. How do we know if medical clearance is needed? Is that something that's specifically from the airline?
So it depends on your airline. So you've got some different stages. If it's an infectious disease, that's a border issue. But usually, and the airline will certainly be interested too, because the airline, there's nothing worse than norovirus on an aircraft seat. Discussed with several airlines that have had that problem. But usually it's going to be an airline issue of, are they happy with the risk of the person flying? Most airlines have decent websites which will help you work through the MEDA or MEDIF forms to complete, to go to the airline to ask for permission to fly. So that involves declaring your condition. It's got good advice about when you don't need to bother with it, which can be surprising. A couple of weeks after a heart attack, often the airline don't care. Air New Zealand's one's excellent. I'd thoroughly recommend Googling MEDA. It's Mike Echo Delta Alpha, or MEDIF, Mike Echo Delta India Foxtrot, MEDIF. And if you look at Air New Zealand, go on Air New Zealand's website, have a look there. They've got a great explanation which you can just click through and work out, do I need to ask permission from an aviation medicine doctor? Next problem you're going to have is the airlines don't want to find this out now before the plane boards. So it's a good thing to ask early to give the airline time enough to process it. Even a place like Emirates, they don't have that many doctors working in there, and if you and they will want to have it well in advance in their time zone, which can surprise you. Some of them is the operator in Australia who subcontracts to Canada, so you want to talk in Canadian time zones. That sort of issue can go on. You want to get the paperwork to them to give them time to comment on it and get back.
Cool, thank you, Kit. Specifically regarding clearance when someone's pregnant, do you have any particular pearls on that?
Yeah, most of the airlines have quite clear policy on it. And unless it's an urgent medical situation, they'll just follow their policy. Usually it's not much of an issue until very close to term, because they don't want a baby on the plane. Having said that, the record of delivering babies on planes isn't actually that bad, but you still wouldn't want to have some complicated delivery. Also, amniotic fluid is really corrosive to aluminium, things that you learn in aviation medicine. So yeah, follow your airline's guide on it. Don't hide the pregnancy. We've had a few people who've done that. And that's the major source of births in flight, actually. It's not people who come really preterm, it's people who lied. Or didn't think about it, or didn't read the print on that one. And if you're dealing with aircrew, somebody who's actually flying, second trimester is not that unsafe. First trimester has got some sudden incapacitation problems, and last trimester, often, particularly towards the end of it, nobody's going to want to be in control of an aircraft. But yeah, the second trimester, depending on where you're flying and for who, can be quite safe to fly.
Okay, we've got a question around testing for respiratory capacity. Someone's got here, is the best test for respiratory capacity still how a person might handle walking up a couple of flights of stairs and their oxygen still over 95%?
If you're a GP and you're looking at a rough, are they going to be okay? That's not a bad one. If you're looking at aircrew, then we do spirometry. The Air Force does spirometry routinely on everybody applying. And a big problem in New Zealand is asthma, because if you want a good, this is something actually to worry about in flying outside a commercial, anything outside a commercial airline environment, triggers for asthma: cold, dry, forced air and a bit of obstruction, which you'll get from an oxygen mask. And then if you're flying a helicopter off ships, which quite a few of our people do, we'll add in some salt sea spray as well. It's a perfect environment for asthmatics. But that's not to say that people who have had some asthma can't fly as aircrew. However, if you look at can the older person with COPD cope with flying, first of all, go to the Med-F guidelines, as just talked about. Secondly, yeah, if they can do a couple of flights of stairs and maintaining 95%, they're probably okay. You are right, though, that the oxygen, your desaturation curve is going to go walkies because of the hyperbaric hypoxemia. So it's a very good thing to be worried about. Also, anything that if you've got bulla sitting there and you're emphysema patient, what's going to happen with that? If in doubt, check with the airline, and it's not an automatic no. They can do things like oxygen in flight.
Okay, awesome. Yeah, most airlines have pretty clear guidelines about things, which are super helpful for us as health professionals. So, Kit, an anxiety-provoking moment for health professionals when you're in public and you're called upon for an emergency. So, do you have a suggested approach that if we're on a plane and we're asked to help a passenger, how we would go about approaching that?
So, concerns people seem to have involve, a lot of it seems to involve, am I going to get sued? Virtually everywhere has good laws to protect you. Go with your conscience and just treat. The standards you'll be held to are those of where you practice. So it doesn't matter if it's a foreign flag carrier and it's working under a different country's laws. Even American flag carriers likely to be pretty safe. Most places you're not obliged to help. Bear in mind, some nations, France, for example, have an legal obligation to help. There is help for you. All the airlines have doctors on who can be rung up and provide advice over the phone to you, and can also clear you. So they'll probably want to know a bit about your background. This happens a lot. I think I've had 7 times I've assisted. Well, I know I have. Why do I say thing? 7 times where I've been called upon to assist on flight. It does help if they know roughly who you are, so they can take the mic and walk straight to you and say, "Hi, we wonder if there's a thanks." Most stuff that you're going to get isn't going to be that major. Aircraft do come with first aid kits, varying degrees of comprehensiveness, but you can expect there's going to be stuff in. There'll be some insulin. There'll be your 300 mgs of aspirin. There's going to be there'll be salbutamol with a spacer. There's going to be the stuff that you need to treat the most obvious. And you can, as I said, get advice down the far end of the phone. A couple of other bits and pieces, things that airlines don't want. They don't want you to turn the aircraft round. Now, because of their laws, if you declare somebody dead, that may result in the aircraft having to turn down, or if you're really unlucky, land over whoever's territory they're over. So I would have a tip of do not declare life extinct. And you may get some tips down the phone suggesting, I want you to tell me if they're not responsive with no vital signs, but I don't want you to use the dead word. So that's the one thing airlines can be quite keen on, in the morbid end of things, and people do die on aircraft. The other bits and pieces, no, you're not necessarily going to get an upgrade to first class because you gave them a hand. The practique stuff I just mentioned, if there's a chance it's an infectious disease, they're going to want to know details. So if somebody's had nausea and vomiting, being able to firmly state, for the benefit of all border officials, yep, I'm confident that that was a viral gastroenteritis of the same sort that you're going to have in your own nation, or I'm confident that they had a bit too much to drink, or whatever, is going to be very reassuring to them. Mental health patients can be amongst the most difficult to deal with, and airline crew, I should have said this, so stewardesses and stewards, people have the idea that their primary role in the flight is to serve them beverages. No, they've got a critical safety role, and they've all had a reasonable amount of first aid training. So their most important job is to get you all out of the plane in an emergency, and the next most important job is assisting should something like this happen. So you'll find that they're really helpful and will actually know quite a lot. They're like the theatre nurse and you're a junior house surgeon. Oh, I wonder if it could be low blood. Oh, thank you for passing the blood glucometer.
Thank you, Kat. So with the scope of aviation medicine, can you tell us a little bit about that in terms of what it specifically does and does not include? Just to clarify, as a health professional that might be interested in this field, so as a health professional working in aviation medicine, what kind of things do you actually do or are involved in?
Right. So I guess the boring part, lots of paperwork, lots of physical examinations of perfectly healthy people, and lots of checking up on things. It doesn't only involve the aircrew. It's really good to be out there and seeing, apologies if you've got the small person in the background and the speaker. It's really important to get out and see the people working on the ground crew. They're involved in exposing themselves to quite a few interesting substances in addition to the noise, and things like closed confined spaces entry, crawling inside a wing full of some interesting fuels in order to put some relatively toxic sealants into places while on a respirator. These sort of things can be quite interesting as well. And it can involve, as I said, it can involve transporting sick people in the back of aircraft or helicopters. I guess that's the majority of what it involves. Teaching, often teaching the pilots and aircrew and the people on the ground as well.
So Kit, in terms of the MEDA guidelines and covering clearance to fly and things, we've just had a question about a situation where that might not nicely fall into the guidelines, where you might be saying, yep, a patient's fit to fly to a destination, but you're worried that they might say become unwell or become unstable, not be fit to fly back. Is that a kind of situation where you'd be asking for advice, or how would you approach that?
Probably there's a two-stage on the matter, and there's the flight out and there's the flight back. So if you think the condition may deteriorate, it's worth noting that to the airline. If you're in doubt with the airline, give the doctors, let them know you want to talk to them and talk to the doctors. Ben Johnson's team at Air New Zealand is excellent, and as are most of the other teams I've dealt with. The question of what, when you're advising the patient, can be, well, what if? And if they haven't got good travel insurance, I tend to look on insurance as right to sue an insurer rather than getting some money for a condition. If you haven't got good travel insurance, the cost for flying back by an air ambulance can be ridiculous. And sometimes you just get stranded because it's a bad idea to fly you. I've certainly seen that with somebody who's come out from, I've actually seen it a few times, with people who've come out from Pacific Islands to get treatment in New Zealand for conditions that are essentially terminal. And they've had a bit of treatment, but they've deteriorated to the point where it's not safe to fly them back. Ship's a bad move. They're now stuck away from their family. Was it a good idea to travel at all in the first place? So that sort of thing can be very relevant. And look out for what your travel insurance won't cover you for. I went to Thailand for some quickie surgery. There were complications. Your travel insurance isn't going to cover it, and the airline may well not want to fly you back.
Okay, we've got a question about rural practicing GPs or other health professionals if there's been an emergency and a rescue flight team has been called. when that team arrives to the rural location in terms of, I guess, leadership and making calls and things like that, if the person's acutely unwell, who would take the reins there?
Okay, so handover will occur as per normal. So some things to be aware of, and those who've worked with helicopters will know this. Compared to a normal ambulance handover, time to stay and play is likely limited. That helicopter wants to get moving again. It's going to run out of crew duty time, fuel, weather. It's not happy sitting on the ground. Handovers tend to be very quick. The military has a set of sort of standardized procedures. If possible, do as much as you can while you're in the air. Some of the services you can actually be posted in and even talk to people while they're on their way there. Bear in mind what you won't be able to do once the helicopter lands. Use your stethoscope. Nope, not unless you move well away from the helicopter. In the back of the helicopter, you're not putting a line in unless you really have to, because it's vibrating the living daylights out of everything. So things that can be helpful would be your standard 214 gauges and a decent set of obs for the sort of things that they'll have difficulty dealing with. Packaging the patient. They can easily get cold, and cold, as you probably all know, is a major problem for things like coagulation. Inside an aircraft, as I mentioned before, tends to be cold. Helicopters, but you can see things like open doors. Now, open doors, if the patient's not well packaged and they've got extraneous bits floating around, I have seen a cell phone go out a helicopter door. More disastrously, we've had one crash recently in New Zealand, which has been because somebody's jacket went out and wrapped itself around the tail rotor, and that killed everybody in the aircraft. So they're going to be tight on the packaging, and that can mean accessing parts of the patient can be a bit more awkward. But again, it depends on very much on the helicopter. Military, for a bunch of reasons, often work with the doors open. Civilian are often able to close them, which makes it much easier.
No, but that's all good, Kit. If you don't have anything more to add, I think that's most of our questions for tonight. So I just want to say thank you so much for taking the time, Kit, to present to us and share your wisdom. And thank you to all of our guests for joining us tonight. And have a lovely rest of the night, everyone. Thank you.